Okay, hi, my name is Selena. I'm one of the new graduates. Next to me, I have Dr. Tai Fan. Dr. Fan, will you introduce yourself?
Yeah, my name's Tai Fan. I'm a dermatologist and MOHS surgeon. We do MOHS surgery at Huntersville Private. And yeah.
Yeah. So now from the PowerPoint that we understand what Mohs surgery is and what it involves, it's important to gain insight into how the tissue is excised and mapped, what the mapping represents. So in front of all of us, we all should have a copy of this sheet, which is a Mohs map from our lovely patient. Our patient is John Smith. Dr. Fan will go through the Mohs map with us.
Right. So in front of you, you see this MOHS map. This is pretty much the operative record for patients when they go through MOHS surgery. So it's a full, complete record of what's taken out and where the tissue was taken out from. So if you've got a copy of this in front of you, you can see that it should have the name of the surgeon, the consent was done at a certain time and date, and then the time that the patient first came into the theatre. The MOHS number, or the MOHS histology number, is assigned in the laboratory here when the tissue comes into the laboratory, and each patient's slides are made. Each slide has a different number, and that's that HH25199, the referral from a specific doctor. Now the diagnosis is the type of tumour it is, so the common tumours are BCC and SCC that we treat. The location in this case is on the groove of the nose, the right alar groove of the nose, and then we mark it out. Before we take the tumour out, we mark out where we think the tumour is, and that's the initial size in 2 dimensions, 3 by 3 millimetres. And the final size is the actual final defect size, which is after we take a margin around that 3 by 3 millimetres, and any subsequent stages, the final hole or the final defect size is recorded as well. And then the repair is just a summary of how we repaired that wound. So that's the top half of that box. There are little check boxes on the right there to remind the surgeon to take photographs before preoperatively defect as well as the closure. But then the bottom half of the page is split into 4 boxes, and there are 4 other boxes or 6 other boxes on the back in case we need to do 1, 2, 3, 4, maybe even up to 10 stages at times. So one stage really comprises us taking a layer of tissue. The first layer of tissue is taken, that's stage 1. The histology number, which I've talked about just a second ago, and then the number of blocks is the number of pieces of tissue that we bring to the laboratory, so separate pieces of tissue. So in this case, you'll see that there's a number 1, which is a little biopsy, and then a circle, which was the circle of tissue that we took out. That's then inked and nicked. There were little nicks that are put into the specimen, so it's oriented. And so I have a code, or every Mohs surgeon will have a code. Dots represent blue, solid lines represents red, yellow is Y, and G is green. So that circle is inked in 4 or 5 different places, so we can orient the specimen if it is positive. And in this case, you can see the little red dot in the sort of just below 3 o'clock. There's some BCC that we saw under the microscope, and so by looking at the slides and then cross-referencing that to where the nicks are on the patient, like little nicks with a scalpel, we can then line up exactly where there was some tumour left. And so in the second stage, when we come back and take tissue from the patient, we just go back to that particular area and just take a couple of millimetres around that area. So that way we save as much normal tissue as possible, and not have to remove a whole 3 or 4 millimetres around everywhere, and that enables us to keep the hole as small as possible, and still get close to 100% cure rate, or 98 to 99% cure rate. So in the second box here on the right, you see stage 2. We went back and we just took a little bit of extra tissue near where that 3 o'clock was, and so that's represented by that little crescent of tissue there, and then that was clear, thankfully. And so we started off with a 3 by 3 millimeter nodule, but ended up with 9 by 6 millimeter defect, and that was small enough for us to just close directly or primarily together in a line, and so that's been able to give the patient a very good cosmetic result. So if we needed to do more stages, then there'd be another stage, and we would I'd draw some more to orient where that specimen's taken. Now, MOHS is different to normal surgery or normal pathology because we check all the edges as well as underneath in one slide or 2 slides. So it's a much more thorough look at the edges of the specimen compared to if you might have seen frozen sections done. They are only taking samples of the edge, so they can't take they can't look at the whole edge in the one go. So that's this MOHS map in a nutshell, Selena.
Thank
Hope
you.
that explains it.
It does. Thank you very much.